Okay, I think we're quorate and ready to start. And welcome to the last day of National Thrombosis Week. It's been an extraordinary week for us at Thrombosis UK. We've had some of the biggest audiences ever, and we are excited to see that many people are looking at the recordings afterwards. So my name is Professor Beverley Hunt. I am the founder of Thrombosis UK and currently a trustee. And it's my real pleasure to run this session today. This is an update on all the research that's going on VTE in the UK, mainly around thromboprophylaxis. And I think one of the achievements of Thrombosis UK has been to really push back very hard against the National Institute of Health research so that they are every year commissioning research around thromboprophylaxis. And I have been talking to them in the last few days, and there'll be another call this year, which looks very exciting. So we're going to go through our current trials, and I'd like to call on Dr. Francine Heatley first. She's a clinical trials manager at Imperial College London and part of the team undertaking the GRACE trial, which is inpatient graduated compression stockings used as an adjuvant to extended duration pharmacoprophylaxis for VTE prevention. And this is going to be a multi-centered trial. So this is just about to set up. I'm going to hand over to her. Before I do, can I ask if anybody wants to ask any questions, please write them in the Q&A session. Either myself or a member of the team can answer them in a written format, or we can discuss after each presentation. So without much ado, Francine, over to you.
Beverley, I think Francine has just lost internet. So
oh dear,
we should go to Sarrah while Francine comes back in.
Yes, so we'll wait for Francine. Sarrah Whittley is another clinical trials manager at Imperial. They have the most fabulous team of clinical trials manager, and she is running the Thrive trial. And I'm going to leave her to talk about this in particular. Over to you, Sarrah.
Thanks, Beverley. Can I just check that you're able to hear me okay and see my slides?
Oh, yes, beautiful.
Perfect. All right, thanks very much for the introduction. So yes, I'm Sarrah. I'm one of the trial managers at Imperial, and it's my pleasure to present to you today the Thrive trial, which is an NIHR-funded study looking at thromboprophylaxis practices in individuals who are undergoing superficial endovenous treatment. So just as a bit of background to the study, varicose veins are a common condition and they affect up to 45% of the UK population. And endovenous surgery is now the recommended first choice management for symptomatic varicose veins as per the NICE guidelines. And around 35,000 of these procedures are performed annually in the NHS alone. However, there's an increased risk of VTE during endovenous varicose vein surgery when compared to other short stay surgical procedures. And VTE occurs at a rate of up to 3.4%, which is actually higher than the rates of VTE following open abdominal aortic aneurysm repair. And so to try and mitigate against this risk of VTE, around 2/3 of clinicians in the UK currently offer some form of pharmacological thromboprophylaxis to their patients. However, there's currently no high quality evidence to support this provision of pharmacological thromboprophylaxis to these patients. And while 2/3 of clinicians do routinely offer pharmacological thromboprophylaxis, some will offer a single dose of low molecular weight heparin, while others will offer an extended course. And then there's also around 1/3 of clinicians who don't routinely offer any pharmacological thromboprophylaxis. So the practice is highly variable. And also the guidelines for these patients regarding thromboprophylaxis are somewhat ambiguous and contradictory. So there is a need for some robust grade A evidence to either support or refute these current practices. And so that's where the THRIVE trial then comes in. And the THRIVE trial is a large study which is aiming to establish whether in patients who are undergoing these endovenous varicose vein procedures, a single dose or an extended course of pharmacological thromboprophylaxis decreases the risk of VTE, whether it's associated with increased bleeding events, whether it's cost effective, and whether any pharmacological thromboprophylaxis affects the rate of VTE. At the moment in the UK, there are currently 3 thromboprophylaxis strategies adopted by clinicians for these procedures, and the arms of the trial mirror these practices. So patients will be randomised equally to one of 3 arms, and the first arm being compression alone, and this is administered as per standard practice. The second arm then is compression plus a single perioperative dose of low molecular weight heparin, and again that's as per local standard practice. And then the third arm of the study is compression plus a single dose of low molecular weight heparin plus an extended course of pharmacological thromboprophylaxis, and that can be either with low molecular weight heparin or a DOAC for at least 7 days. So the IMP which is administered is dependent on local practice and preference, and so we've tried to be as inclusive as possible with the IMPs in the protocol. So the low molecular weight heparin that can be used can be either dalteparin, tinzaparin or enoxaparin, and then the DOAC that can be used for the extended course can either be rivaroxaban, apixaban or dabigatran. And these are prescribed clinically and administered in line with your local protocol. So pharmacy don't necessarily need to be involved in this trial, and they can adopt an oversight only role. The primary outcome of the study is any imaging confirmed lower limb DVT with or without symptoms, or else PE with symptoms within 90 days of varicose vein treatment. And then secondary outcomes include individual components of the composite outcome, quality of life, mortality, cost effectiveness, and we'll also be doing an exploratory analysis to assess how well the Department of Health Risk Assessment tool and the Caprini score can predict outcomes. And then safety outcomes include any bleeding events. So this is a multi-centre assessor blind randomised controlled trial, and the primary outcome will be assessed blindly. And the trial will take place in both NHS hospitals and in private clinics that are currently already delivering these endovenous varicose vein procedures under local anaesthesia. And in total, we hope to recruit 6,660 participants to the study. So patients will be eligible if they're adults who are scheduled to undergo endovenous treatment of truncovaricose veins under local anaesthetic. And then in terms of the exclusion criteria, we've tried to remove most participants who have any contraindications for anticoagulation or who would otherwise be classed as high risk for VTE. And anyone who's had any non-venous surgery that required a local VTE risk assessment, or any major trauma or stroke within the previous 90 days, that would also be exclusionary for the study. And it's currently unclear as to whether or not asymptomatic screening for DVT is a worthwhile investment for these procedures. And so all patients in this study will undergo a full lower limb venous duplex scan to identify any asymptomatic DVT, and that's including EHIT 3 and 4 as well. And we are conscious that this is out with standard of care, so this scan will be reimbursed at £100 for each scan that's conducted. Consenting to the study can be done both in writing and electronically, and participants will also be followed up centrally by the team at Imperial at 7 and 90 days post-procedure. And sites will receive £145 for each participant who is eligible and who is randomised to either of the 2 intervention arms. And for anyone who is eligible and randomised to the control arm, sites will receive £139. And the study has also been registered on the NIHR Associate PI scheme, and that's open to all healthcare professionals who would like to gain some research experience. In terms of the study timelines, recruitment commenced in January this year, and we're currently in the 9-month internal pilot phase. And the internal pilot will close later this year at the end of September, and then recruitment for the study will end in March 2026. So this slide just shows where we're at in terms of that internal pilot criteria. So the blue line represents our target figures, and then the orange line represents our actual recruitment figures. So we've recruited 136 participants so far to the study, 19 of which have been this month. So by the end of this month, we're hoping that that orange line will continue to be on an upward trajectory. However, we are still a bit behind on recruitment if we want to at least meet that amber criteria for the internal pilot. So we would be delighted for any new sites to come on board and support the study. And again, it's open to both NHS sites and private sites as well are welcome. So if you are interested in supporting the study, or if you have any queries at all regarding the trial, you can reach out either directly to myself, or you can send an email to the Thrive trial inbox. Also, the CI for the study is Professor Alan Davies, and the co-CI is Mr. Daniel Paradise. So you can also feel free to reach out to them with any queries or concerns regarding the study. Thanks very much, everyone, for listening. I'm happy to take any questions that anybody has.
Thank you very much, Sarah. Very clear presentation, an enormous trial. So that will hopefully give the definitive answers to what is the best form of thromboprophylaxis after varicose vein surgery. I can see there are no questions. Do any of the team want to ask any questions? No, well, that's a tribute to how clear you've been, Sarah. So thank you for your presentation. I hope you'll hang around. I'm glad to say that Francine is now back with us, and she's going to tell us about the GRACE study. Over to you, Francine.
Great. Good morning. Sorry about that earlier. Yes, so I'm going to talk about the GRACE study, which is assessing the use of graduated compression stockings in patients that require extended duration pharmacological thromboprophylaxis post-elective surgery. So I'm not sure if Sarah went over the background for her study, but essentially for GRACE, we're also talking about hospital acquired thrombosis. So any VTE event within 90 days of hospitalization. And this did account before the rollout of thrombosis prophylaxis, 32,000 fatalities per year, and it was expensive. And as you know, surgery is an established risk factor for this. And certain types of surgeries do come with a higher risk of VTE, and these do require the extended duration thromboprophylaxis post-surgery. The NICE guidelines recommend that patients undergoing this surgery, this group of patients as well, also have graduated compression stockings, but they also come with a cost around 8 million a year and a complication rate of 5%. Just a bit of background, there was a Cochrane review previously that included, that did show a benefit for the stockings, but it included a lot of small trials, and they were funded by the stocking manufacturers themselves. And they did exclude 2 major studies into stroke and orthopedic patients, which didn't show benefit for the stockings. And we also did the GAP study from this group, which didn't show a benefit in moderate and high risk group for VTE. And we also did an updated systematic review last year, which didn't show a benefit for the stocking. So that's why we're going to do this study. And as I said, we're looking in the extended duration thromboprophylaxis group. The exclusion are patients 18 years or older and assessed as requiring the thromboprophylaxis post-discharge. And exclusions are any contraindications to this or the stockings, and any patients on therapeutic anticoagulation at the time, and any known thrombophilia or thrombogenetic disorders. And then the primary outcome again is imaging confirmed lower limb DVT with without symptoms, or PE with symptoms up to 90 days. And we're also looking at some secondary outcomes and mortality and adverse events to the stockings, plus adherence to the stockings and the thromboprophylaxis. We'll be randomised patients to the extended thromboprophylaxis plus the stockings. That's the control group because that's usual practice. And then the intervention group will be without the stockings, so just the extended thromboprophylaxis post-discharge. We need nearly 9,000 patients and we'll be recruiting from about 40 to 50 sites. From our previous feasibility work, these are the surgeries that usually require the post-discharge thromboprophylaxis. So the biggest group seem to be the total hip and knee replacements from orthopedics. And then there's colorectal cancers and gynae oncology surgeries also require it. And then there's also cohorts of parents in the upper GI and neurology. So we're looking to recruit from across all those specialities, but any surgery that does require this is eligible. It's a pragmatic study, so we're saying any of the thromboprophylaxis you'd normally use, so low molecular weight heparins, the DOACs, aspirin, and then with the graduated compression stockings, we allow below or above knee compressions, and the stocking use would just be as per your local policy. So it seems that most sites tend to prescribe these until discharge, but post-discharge also find just whatever you'd normally do in the control arm, and then take away the stockings in the intervention arm. The follow-up is similar to Thrive, so we're doing it remotely at 7 days, 21 and 35 days and 90 days with self-reported VTE outcomes. But we also do have this additional scan at 21 to 35 days, and that's time to capture the peak onset of events. And that is reimbursed at £140 per scan. I know that's obviously the most important bit, the reimbursement there. So this is just a summary of the study, showing the central follow-up here and then the scan at this time point, and we'll need around about 4,000 participants per arm. These are the cost reimbursements. So there's £42 for the recruitment consent of patients, 140 for the duplex, as I said, and then other associated monitoring and archiving costs. And then this is just a summary of the timelines of the study. So we're at the moment, we're in month 5 here in setup, and I'm pleased to say we just randomized our first patient last week. So that's great. And then recruitment will run for 2 years from the 1st of July. So that's till the end of June 2026. So, and we'll be opening sites throughout that time. So we do need up to 40, 50 sites. So please do get in touch if you'd like to join. Again, it's an NAHR study, so we do offer the associate PI scheme, which is a great way to get trainees involved and also sort of share the burden of the workload. Yeah, so I don't know if you've got any questions. That QR code will just take you to the website if you want some more information about it. Again, just email gracetrial@Imperial if you want to get in contact, or the contact details are on the webpage as well. Thank you.
Thank you very much, Francine. Now, this is an enormous trial. I mean, the others are pretty big, but this is big too. To get 9,000, are you going to entirely concentrate on the UK, or would you be open to having centres from Europe? I think we have to ask that. I know there are a lot of non-British attendees here.
Yes, I think initially we're just looking at the UK, but I think, yeah, that could be a possibility. I think we might need European sites. At the moment, the protocol is targeted to the NHS sites, but yeah, I think we could definitely look at that. And
who should they contact? Do you have an email address?
Yes, so that one on the screen there, that gracetrial@imperial.ac.uk, or my email there as well. And
okay.
Yeah, and we're on the web.
That's gracetrial@imperial.ac.uk, right at the bottom of the screen, which is just visible for most of us. Well, thank you very much. Another very clear presentation from the Imperial stable. And we're going to move on to an even bigger trial that's actually running at the moment. And I'd like to welcome Sarrah Peerbux, who's another clinical trial manager for this PET study. Again, working with all the other members of the panel today. And she's going to give us an update of where the PET study has got to. Over to you, Sarrah.
Thank you very much, Beverley. Can I just check, can everyone see my screen if I make it full screen now?
Yes, beautiful. Thank you.
Fantastic, brilliant. So thank you very much for the opportunity to present today. My name is Sarrah and I'm a trial manager based within the team at Imperial College London, and I'll be presenting on the PETS trial, which is an NIHR funded cluster randomised controlled trial evaluating the benefit of graduated compression stockings for the prevention of VTE in patients who are assessed as low risk for VTE and who undergo short stay surgical procedures. And the study is led by Professor Alan Davies, and Professor Hunt is a co-applicant on the grant. So Fran has already provided a useful overview on the role of stockings, so I won't spend too much time on this, but we've heard that the benefit of stockings have been called into question in other patient cohorts. And from a clinician's perspective, stockings can be costly and time consuming to apply. And from a patient perspective, they can be uncomfortable to wear, they can result in adverse effects for the patient, and that's associated with poor compliance. And again, we have already heard about the NICE guidelines and the interpretation of NICE guidelines. The interpretation of current NICE guidelines means that patients who receive a general anaesthetic for day case or short stay procedures are still receiving stockings despite being ambulant and discharged early or on the same day. And again, as previously outlined, the benefit of stockings has been called into question in other patient groups. And in terms of what we know about the role of stockings in this cohort of interest here, so low risk short stay surgical patients, there appears to be a lack of evidence. And a recent systematic review led by one of the co-applicants on this grant, Mr. Matthew Machin, which aimed to assess the role of stockings compared to no VTE prophylaxis in the prevention of hospital-acquired thrombosis, failed to identify a single relevant randomised controlled trial. So taken together, there appears to be a limited evidence on the use of stockings in low-risk, short-stay surgical patients, and this is despite their widespread use in the NHS and at considerable cost. And so all the evidence or lack of evidence points to the need for the PETS trial, where the main aim is to evaluate the benefit of stockings for the prevention of VTE in patients who are assessed as low risk for VTE and who undergo short-stay surgical procedures. So the primary aim or objective has already been stated. And in terms of secondary objectives, we're also looking at comparing mortality rates and quality of life in the stockings versus the no stockings group. I'll come on to those groups in a moment. We're also looking at identifying adverse events associated with wearing stockings, and we'll also be performing a cost effectiveness analysis. So this is a large trial aiming to recruit 21,500 participants across at least 50 sites. And this is a cluster trial, which means that randomization occurs at the site level rather than at the individual participant level. And patients will be recruited from hospitals which offer day case or short stay surgical procedures, and sites will be randomized to either issue stockings or not. And importantly, trusts can choose the specific individual specialties that they'd like to involve in the trial, but we do expect that trusts accept the site randomized allocation as their standard of care. So either stockings or not. So because of the nature of this cluster trial, participants only need to provide consent to be contacted for follow-up. And again, similar to Thrive and Grace, follow-ups are conducted centrally by the team at Imperial at 7 and 90 days post-procedure. And consent can be obtained at any point up to 7 days post-procedure. So consent can be obtained before the day of surgery, on the day of surgery, or up to 7 days post-procedure. So there's a large window from which patients can be recruited. So there is a fairly comprehensive eligibility criteria, but to put it very simply, patients are eligible if they are assessed as being at low risk for developing VTE using the Department of Health risk assessment tool. So the absence of any risk factors as per the risk assessment tool, which I'm sure we're all familiar with, was displayed here. And again, follow-ups are conducted centrally by the coordinating centre. They are performed remotely, so patients are contacted either via telephone, email or SMS at 7 and 90 days. And at 7 days, we're collecting self-reported VTE outcome data. We're also collecting quality of life data using the EQ5D. And where applicable, we are collecting information on adverse events associated with wearing the stockings. And at 90 days, we're again collecting self-reported VTE outcome data and quality of life data. And there is an additional healthcare resource use questionnaire. And here we have a diagram illustrating patient flow throughout the trial. So in terms of an overview or an update to date, so recruitment commenced in September 2022. We have recruited just over 7,200 participants to date across 53 sites. Recruitment is currently due to end in March next year. We are indeed looking for additional sites, and we can recruit from both NHS and non-NHS, so private hospitals. So if you do know of any colleagues who might like to get involved, if you would like to get involved yourself, or if you'd like to obtain a list of participating sites to see if your site is involved in this study, please feel free to contact us at petstrial@imperial.ac.uk. Sites will receive £28.20 per eligible patient who has been consented. And the study is also registered for the NIHR Associate PI scheme, which is a fantastic way of getting colleagues involved in research. Thank you very much.
Thank you, Sarah. I run a centre as part of the study. Do you want to just talk very briefly about some of the recruiting difficulties that we've had?
Yeah.
For me, I think one of the big ones, we are screening a lot of people, but not all of them are eligible because the number of low-risk patients having short-term surgery is quite small, isn't it? And one of the big issues is the obesity epidemic, in that we want non-obese people, and we have got a very large population in the UK. We are the fat man and woman of Europe, and about a third of our population are actually obese, so we can't recruit them. Do you want to just discuss that briefly?
Yeah, absolutely. I think different sites are reporting kind of different issues. Each site has, different contextual issues that might be affecting recruitment. One of our kind of common pieces of feedback is around this patient population, patient demographic issue. So sites are often reporting that patient population just isn't there, and many patients are being screened out on the basis of age and BMI. So a lot of patients are over the age of 60 or have a BMI over 30. And obviously this kind of precludes enrolment in the trial. You might be interested to know that although we've recruited just over 7,200 patients to the trial, the study has also screened out some 26,000 patients, and approximately 50% of those 26,000 have been screened out on the basis of being assessed as moderate to high risk of VTE, largely due to age and BMI. Sites are often reporting issues with staffing resources as well. So sites are often kind of under-resourced to recruit to the trial, and this is something that we can help with by exploring additional workforce support via the local clinical research networks. Sites are often unaware of the support that they can obtain via the clinical resource network scheme. So if this is something that, if staffing resources is something that you are concerned with, please don't be concerned, because we can explore additional support. And quite interestingly, this was a surprise certainly to myself and also Professor Davies and Mr. Shaloub, the joint lead investigator. A large proportion of sites are reporting issues with the VTE risk assessment, in that they're either not being completed correctly or they're not being completed at all, which is obviously important from a patient safety perspective. But again, it affects patient enrolment into the trial. If sites don't have a VTE risk assessment, they can't enroll the patients, they can't confirm eligibility. And obviously, Beverley, we're working separately with you on launching hopefully a survey to assess kind of attitudes and behaviours towards the VTE risk assessment.
So I think the attitudes to VTE risk assessment is an old chestnut, because we're looking really at day surgery cases, and the surgeon thinks the anaesthetist should do the risk assessment, and the anaesthetist thinks the surgeon should do it, and between them they don't do it. Many of us are bringing in hard stops to our electronic systems to say you can't prescribe for your patient until you've done VTE risk assessment. And I think the other thing that's going to change it all is we now know that nationally in the, NHS England, we are all going to have to return our rates of VTE risk assessment and have more than 95% risk assessed to NHS England. We're in a bit of an odd situation at the moment. They said, oh, we're going to start it now, but they haven't given all the details of their website yet, but we will be doing that. So that should change. And then your other point about finding funding for a research nurse. Sarah, you've been absolutely amazing in helping me get the extra funding from the CLRN for my research nurse. And so they do have pockets of money. And Sarah is brilliant at finding them. I don't know how you do it actually, but we did pursue lots of different avenues. And so we've got another 6 months funding for our research nurse to do this study. So when there's a will, there's a way. And when you've got your practical knowledge and you never give up, I think it's the way forward. So I would encourage anybody on this call who isn't part of this study and they want to be part of this study to contact Sarah, because she will enable you and help you set up. Okay, so thank you very much. So we've come to the end of the Imperial College team's presentations. What a wonderful job you're all doing. And we're going to move on up to Manchester. And I'm really delighted to welcome Professor Dan Horner, who's a consultant usefully in emergency medicine and critical care, and he works for the Northern Care Alliance NHS Foundation Trust, which is the new term for the Manchester hospitals. And excitingly, he's leading us in the UK in trials in lower limb immobilization that come under the heading of TiLLI. Over to you, Dan, to tell us where you've got to. Thank you.
Thank you very much, Beverley. Very kind introduction, and as always, very happy to be of use. So that's good. So can you see those slides, just to double check? Yeah, great. Okay, so I've got a little bit of time to talk to you about TiLLI, which is work around thromboprophylaxis for lower limb immobilization. And this has been a research interest of mine for the last decade or so. I was asked recently on a podcast where it stemmed from, and I think it probably arose from seeing a few very challenging index cases in the emergency department of young people coming in with serious illness as a result of VTE, having suffered what they believe to be a fairly innocuous lower limb injury. And then my research MD was aligned to thrombosis, and perhaps the combination of those two things got me really interested in this topic. It got me looking at what other countries do, and it made me realise that actually we all do very different things, and we don't really have the answers to this problem. I'm at the very end of my talk. So let me back to the start. I suppose having become interested in it, and doing a bit of digging around, it becomes very clear that the media are very interested in it as well, that it continues to be a real patient safety issue, and that these kind of tragic events happen regularly and continually. So every time I'm asked to do a talk like this, I have a look around to see if there have been any cases reported, and sure enough, some of these are from the last 12 months. So this is the kind of problem that we do see arising. We've made lots of progress, but it continues to be difficult. And some of it, I think, is around the horrible consequences of these patients being often very young, again, having suffered fairly innocuous injuries, often not really realising that VTE was in any way a potential risk of their twisted ankle, and so the surprise makes the case very emotional for all involved. But they're just anecdotes, so I think it's important for us to dig in a little bit to the evidence, and when you do that, you see a fairly consistent rate of symptomatic VTE with lower limb immobilization across a number of randomized controlled trials spanning almost 2 decades now. And this rate of between 2 to 3% is not entirely miles away from the rate of hospital-acquired thrombosis in some cohorts. I think we just saw 3.4%, didn't we, in one of the previous presentations. So, levels of risk that are approaching those associated with being in hospital, which of course, we have very robust mechanisms to try and to deal with and mitigate those risks. And you can look at it in different ways, I suppose. You can look at these numbers being fairly low in terms of absolute value, but when you apply them to a denominator of around 70,000 patients per year going into plaster casts in the UK alone, then just reducing that risk from 2% to 1% would probably save us around 1,400 clots a year with all of the allied morbidity and mortality. And if we allow those clots to happen and we treat them with therapeutic dose anticoagulation, then we're into around 125,000 days of therapeutic dose anticoagulation. So a big health problem. If you compare lower limb immobilization to ED patients who attend with a hand injury or wrist injury, for example, the risk with lower limb immobilization is around 6 times that of any other patient attending the ED with simple orthopedic trauma. And what can we do about this? Well, we can treat it with thromboprophylaxis. And we do have quite a lot of evidence in this area, but some of it is conflicting. Some of it is not quite perhaps as valid as we would like it to be, or externally generalizable. When you look at the different trials, some of them are small, they're often in a single country. But they do suggest that thromboprophylaxis in this cohort will probably reduce the risk of VTE by about 50% in that patient cohort. So we published a systematic review and network meta-analysis looking at this in 2019, and that's been developed by Delphine Doulier and colleagues in France who published a Bayesian network meta-analysis in 2022. And the black lines here demonstrate trials brought together that have directly compared one thing to another, and the dashed lines are inference, I suppose. So there's no trial data comparing these two therapeutic interventions head to head, but from a network meta-analysis, you can perhaps estimate risk reduction, try and work out what might be better. And you can see here that the evidence for use of aspirin is actually very weak. There's very little head-to-head comparison with any usual therapies or against control. The data is best for low molecular weight heparin, where we have large numbers of patients randomized to receive that compared against control. We have some data on DOACs, mostly from non-major orthopedic surgery, rather than patients just put into a plastic cast and discharged home with no active follow-up and no interventions in the future. So small amounts of evidence kind of coming through there. And of course, we do have some data on fondaparinux as well, but still lots of questions. Now, one of the questions that always arises when we look at this topic is, well, if thromboprophylaxis works, why don't we just give it to everyone? And the concern with that is that perhaps it wouldn't be cost effective. So if you're talking about a baseline incidence of 2% in patients with lower limb immobilization in terms of VTE risk, even if we halve that to 1%, that's only an absolute risk reduction of 1%, which means you need to treat probably 100 people with thromboprophylaxis in order to prevent one clot. So that's a lot of low molecular weight heparin if that's what we're using, and that's, I suppose, some potential risks of bleeding and side effects from thromboprophylaxis, but more importantly, it's expensive. So we tried to look at this question of cost effectiveness with a decision analysis model funded by the NIHR in 2019. And the decision analysis model is very clever. It wasn't something I had any expertise in before I got involved with the team in Sheffield, but I found it really interesting. Essentially what they do is they build a computer model of all the possible eventualities in this kind of situation. So we start with someone with lower limb immobilization. We say, okay, we could give them prophylaxis or not. We could give them prophylaxis according to some form of risk assessment model, and then we could choose where the bar was within that risk assessment model. Whatever strategy we decide, they could go on to get prophylaxis or not. Whatever we give them, they could go on to develop a clot or not, or a bleed or not. And you can follow these nodes all the way down really to a 3-month position of follow-up. And you can estimate the risks of clotting and bleeding in all of those nodes, and you can put a price on it. And interestingly enough, when we did that in 2019, what we found was that thromboprophylaxis would be highly effective by any NICE measure or any NIHR measure of cost effectiveness. So the dotted green line here is the cost effectiveness threshold routinely endorsed by NICE when it comes to review evidence and make recommendations on treatments. And as you can see, all of our black dots here are well below the green dotted line. The top dot is thromboprophylaxis for everyone, which is expensive, but it gives you perhaps the most quality adjusted life years. So along the x-axis, we're the furthest to the right there. And then we took what we felt was the most effective or the most clinically effective risk assessment model at the time, the L-TRIP-CAS score, and we started to plot in, well, what would happen if we gave thromboprophylaxis according to a risk model in these patients. And we go from 6 to 10 as the black dots go down here. And what we found was that you started to lose quality adjusted life years. The higher your bar becomes the thromboprophylaxis because you start to miss clots. It does get cheaper because you give less levodopa heparin. And there probably is an absolute peak of cost effectiveness somewhere around a risk assessment model with a sensitivity of 80 to 90%. So a risk assessment model perhaps could be useful in future, but none of the risk assessment models we had at the time were particularly valid. But other authors have published different work on this topic. So this is one recent abstract from an ISTH conference in London. I think this one was from the King's Group, who use a very, very simple risk assessment model involving, I think, cancer, pregnancy, previous VTE and Achilles tendon rupture. And if you don't have any of those things, they don't offer thromboprophylaxis to the group. And this retrospective piece of work looking back through their data set to evaluate the risk of downstream VTE suggested with that method, they had a very, very low risk of symptomatic VTE. And of course, in North America, they don't really do anything about this. Their national guidelines don't recommend any risk assessment or any thromboprophylaxis for ambulatory patients in plaster cast. Whereas in France and Belgium, they give some form of thromboprophylaxis to everyone. So ongoing discussions and ongoing research questions, really, some of which are summarised here and we've highlighted in different review articles. So, are there any risk assessment models that are accurate and efficient in terms of prescribing prophylaxis? Orthopedic management is changing all the time, isn't it? So rather than everyone going into plastic cast, we see a lot of patients in removable splints now. And do we apply the same logic to them? Are they still immobilised? Can we start using more DOACs for this indication despite the lack of evidence? And some people obviously get clots despite us prescribing thromboprophylaxis. So what about heterogeneity of treatment effect? Are there patients we need to identify at particularly high risk who perhaps need higher doses of levodopa heparin or higher doses of thromboprophylaxis? And everyone always wants to talk about aspirin for some reason. I'll never quite understand why. I think it's because it's very cheap. We've used it for years, so people think it's very safe. Actually, the data in this particular cohort would suggest that bleeding rates are fairly equivocal with aspirin and levodopa heparin and DOACs because the patient population is usually quite young with limited comorbidity. But people keep asking the question. And the NIHR have taken notice, which is great. So there was a commission call on this last year following several James Lind Alliance priority setting partnership exercises in terms of research questions, a recommendation by the Royal College of Surgeons, some recommendations by the Royal College of Emergency Medicine, and the NIHR offered a commission call on the clinical and cost effectiveness of thromboprophylaxis in patients with lower limb immobilization. Now, the pros and cons to a commission call, the pros are that they're obviously very keen to fund a research application, and they've already acknowledged the importance of the question. But the cons are they can be quite vague about some aspects of the call, and they can say authors to justify, as they have done here, around various bits. And they can also be quite formulaic about how they approach the research question, which might not necessarily be the way that you wanted to approach it, which I'll perhaps come on to. But a commission call, which is great in our area of interest. So the first thing we tried to think about was identifying different levels of risk in this population and how we would acknowledge that and how we would report it transparently in a trial. And there are probably 5 or 6 different risk assessment models for patients with lower limb immobilization now available in the published literature. What we wanted to do was identify one that had been externally validated and where there was a threshold that met our definition of most cost effective based on our previous work. And luckily we found that through the TripCast model. So this is a score that's been developed again by Delphine Dulier and colleagues in France. It built on the LTripCast score, but it was refined following validation in a number of external data sets. And it's recently been validated across a large emergency medicine cohort in France and Belgium, where they applied this score as a step wedge cluster design following a 6-month period of usual care, and they looked at VTE rates following implementation. And you can see here that this score at the proposed cut point identifies low-risk patients with a relative degree of accuracy, so a VTE risk below 1% there. It's also published in the Lancet, which is very helpful in terms of getting the NIHR to recognise the importance of the score and the validation of the score, its robustness in terms of scientific evaluation and peer review. There's also a lovely app for the TripCast score, so you can all experiment with this at your leisure. It's downloadable to every mobile device that allows you to calculate the score at the bedside and then make a shared decision with your patient about their risk of VTE and what you might want to recommend. So now we have a score that allows us to separate high risk and low risk patients with lower limb immobilization. I suppose we have to think about what lower limb immobilization is, and the Commission Court wanted us to define this and justify our definition. This is what NICE has to say, and I think it's quite vague. But it's all encompassing, which I think is helpful, because one of the problems we've had with this topic is that when we publish some research on the risk in plaster casts and the treatments, all of a sudden they start using weight-bearing air cast boots, and then people say, well, you can't possibly apply the evidence from plaster cast to air cast boots, and you need to go back to the start and do the whole trials again. And actually, NICE's definition is all encompassing there. So we try to address this and tackle it, because we think this is quite a broad group, and it will continue to develop, and so the more data we can get on it, the better. But what we have done is we've gone back to the TripCast authors who have a section in the score to identify the risk based on the type of immobilization, and we've tried to align that with UK definitions and UK practice, given that we were proposing a UK-based trial. So these are a variety of orthopedic immobilization devices, some of which I'd never seen before until we started this, but many of which I do recognise. And we've now created a separate document within the study that affords different points on the TripCast score and different bits of embedded guidance within our trial proposition to score various points and to build your cumulative TripCast score. So hopefully aligning with UK practice and hopefully future-proofing any results from the trial. Then the thing that caught us slightly off guard with this commission call was that they wanted us to look at patients at low risk of VTE as well. And we hadn't really expected this. What we'd expected was a commission call on, okay, the evidence base is building towards using thromboprophylaxis for those patients at high risk of VTE, and the evidence base is suggesting we need more work on DOACs versus low molecular weight heparin. So we geared up for that, but what they actually said was, well, we don't think the evidence base is good enough to make any recommendations properly about those patients at low risk of VTE as well, because it may be that they stand to benefit from thromboprophylaxis if you're telling us it's cost effective to give it to everyone, and if you're telling us that the risks of complication or side effect or bleeding are very low in this group. And this was surprising, but when we sat down with our convened patient and public representation group, actually had some really interesting discussions around risk and around risk consequence. And one point several patients made in our group is that absolute risk is not necessarily their overall concern, as it often is through doctors and healthcare professionals. What they really want to know about is the consequence of that risk. So, if the absolute VTE risk is 1%, but the consequences of getting a VTE may be death, or they may be post-thrombotic syndrome, or they may be chronic thromboembolic pulmonary hypertension, then they really want to know about that. And they want to have a discussion at the bedside about use of thromboprophylaxis, and they want to weigh up the pros and cons of taking a medicine for 3 months to reduce that risk, even if it's absolute small risk. So the NHR are probably on the right lines there, but that made us slightly rethink our trial design. It made us think about how we would build an all-encompassing trial to recruit all of these patients at different levels of risk, but perhaps design the trial slightly differently. And what we've gone for is a non-inferiority design in the high-risk patients. So we're going to use the TripCast score to risk stratify a higher risk population, and then we're going to randomize those patients to just receive either low molecular weight heparin or DOAC therapy for a period of the duration of immobilization, or up to 42 days, whichever is shorter, because I think the overall evidence base is built towards not letting these patients manage without any prophylaxis. In the low risk group, though, we're going to use a superiority design because we're not sure the evidence base is there to recommend prophylaxis in general. And we're going to compare low molecular weight heparins versus DOACs versus usual care, which is no drug within a UK setting. And building those trials together, we're in the same territory as some of the Imperial studies, so around 9,500 patients. So big studies, hopefully future-proofed, hopefully giving us concrete answers to this problem, which has been difficult for a long time. Just a couple of points, I suppose, on trial design and trying to address any issues prior to recruitment. So, lots of potential questions along this patient pathway, one of which has been, well, what about those patients who break their ankle and they come back 5 days later for orthopedic surgery? I don't like giving DOACs to those patients because then how do they get an anaesthetic? We've tried to tackle that by stakeholder engagement. So we've talked to all of the societies along the bottom row here about what their recommendations would be. And we have recognised that international guidance is perhaps very cautious around the use of spinal or neuraxial anaesthesia in patients taking DOACs, and often recommend cessation for 24 or 36 hours prior to any intervention. So we've produced some perioperative guidance for trial patients. A lot of these patients will again be young without comorbidity and should be easily anaesthetizable using general anaesthesia. So hopefully we can avoid spinal or neuraxial block, but if that's an absolute preference of the anaesthetist or the patient, then we've made some recommendations about cessation of DOAC according to usual trust policy. We've been asked about information and whether we're going to produce our own trial information sheets, whether we're going to use national ones, whether trusts can continue to use their own. And actually looking at this question has cheered me up quite a lot, because it showed me how far we have come on with this problem, because the majority of trusts now, in accordance with the NICE quality standard on thromboprophylaxis and lower limb immobilisation, will offer some form of local risk assessment, and they will offer some form of local information about the risks of VTE and what to do if you suspect symptoms, where to go and who to raise it with. So we don't want to put a brake on that, and we're going to support the use of local information sheets within the trial. But I'm working with Joe and Thrombosis UK and hopefully Beverley as well to try and develop a national patient information sheet. And that will go hand in hand with, of course, the patient information sheet that we're obliged to present to patients who are thinking about participating in the trial. So hopefully, a barrage of information that highlights risk and highlights the clinical pathways for patients who are worried. And then the last thing we're doing at the moment, I suppose, whilst we submit the protocol, whilst we obtain ethical and MHRA review, having secured funding for this study, and while we develop ourselves looking for a recruitment start date of September, is we're trying to engage stakeholders. So I was at the VTE Specialist Network last week. Xavier and I have published some work on thromboprophylaxis for the trauma and orthopedic surgeons, trying to engage that community. We've done some work with the emergency medicine community as well to try and build up equipoise or make it clear what this trial is trying to achieve. And of course, Beverley and Xavier have published an editorial around Delphine's casting study, looking at the trip cast study in particular. And hopefully this body of work will continue to highlight the problem and make people want to engage with the trial. And we have our NHR funding page in our award now, and we will continue to build on that as a resource for anyone who wants to look in a bit more detail at the design of the study and who wants to get involved in the future. We have selected our initial 10 pilot sites, and we're currently in setup with all of those, but we are looking to deliver this trial across 30 UK NHS sites. We haven't selected our next 20, so we'd like to hear from anyone who wants to get involved. And we'd like to hear from anyone who has any suggestions about trial delivery and how we can effectively recruit. I'll stop there. Very happy to take any questions. Thanks for your time and attention.
Thank you so much, Dan. It's fantastic work. You're going to be so busy over the next few years. There's a question in the chat saying, before you even started, when can we expect results from TiLLI?
So the funding envelope is 5 years. We haven't recruited a patient yet. We've got 9,500 to go. The timeline, the Gantt chart, is a 3-year recruitment period. So I would hope results would be out 2028, 2029.
Okay,
it might be worth mentioning that Delphine is in tandem recruiting to a RiverCast study, which is a high-risk population randomising patients to DOAC versus limb-lethweight heparin. They're only recruiting 1,500 to 2,000 patients. Their results might come earlier. We're looking to combine the two trials with an independent patient data meta-analysis.
So really, we should be encouraging everyone in the Q&A who's asking questions to be part of the study. There was another question saying, when should I use a DOAC? And I think, well, enter your patients into the TiLLI trials. That's really the answer, isn't it? So we can all find out together. I don't think there's any more questions. Is there anything else you'd like to say, Dan?
There's just one question I can see about elective foot surgery.
Okay.
Yeah, which is a complex area, isn't it? And I know there are international guidance now on thromboprophylaxis for elective foot and ankle work, which I think mostly touch on risk assessment, don't they, and trying to stratify patients. In terms of TiLLI, we won't really be recruiting elective surgical patients because that's a slightly different pathway with a slightly different risk profile. But we will be recruiting patients who go on to require a semi-acute operation, so over the next couple of weeks. So certainly operative intervention isn't an exclusion for TiLLI. Okay.
Thank you very much. I hope you'll hang around because next we have Professor Xavier Griffin, who's a big pal of yours, and you are working with him on the trial that he is going to talk about. I think out there, most people haven't been aware that there is going to be a trial called the DIRECT study. And I know Xavier has tried for years to get funding for this, and he finally has. So I'm going to leave him to tell you all about this exciting new study. Xavier, over to you.
Thanks very much, Beverley, and thank you for inviting me. I hope the sound's not too bad. I'm in a slightly echoey room. So my name's Xavier Griffin. I'm a professor of orthopedic surgery based in Bath. So you might wonder what I'm doing here as an orthopedic surgeon, slightly out of my comfort zone. But as Beverley said, I've been involved in trying to get a study funded for some years. And I thought it'd be worth just starting off with a little bit of the backstory and history to that and how we got to this place, because I think it does exemplify a really virtuous cycle that we can develop in the UK with the systems that we have. So I joined the NICE committee for VTE prophylaxis, and I can't remember when we did that, Beverley, but it was a while back, 2018 or something like that. And time flies. And one of the research recommendations there was that people that sustain a hip fracture, we really have very little evidence about how we should best proceed with VTE prophylaxis in that particular population. And there is a trial, and amazingly, given how uncertain we are in the quality of that evidence because of some really fundamental methodological problems in the PEP study, that was done in 2000. It's been heavily criticized in the literature for 25 years now. And NICE felt that it was so uncertain as to how to interpret it that they wouldn't be able to involve that study in the recommendation. And so they made a research recommendation, and that then generated a means for us to apply to an IHR. And we have been successfully funded. And hopefully at the end of the DIRECT study, which will answer the question, we'll be able to feed that back into the NICE guidance. So I really would endorse everyone, if they can, spare the time to get involved with NICE. I think that they're a fantastic organization in many ways. So what is the PEP study, and what's the sort of clinical question? Well, as I say, it's the hip fracture population. And there is a body of uncertainty around whether we should use low molecular weight heparin, or whether in this particularly frail multi-morbid population, we could achieve some better benefit with extended duration aspirin. And that's going to be relatively controversial to some of the people on the call, but that's sort of the state-of-the-art position where we're at with the clinical question. But there's some really fundamental problems when you think about how to design a study that can answer that question. And the issues that the committee were grappling with was, how do you conduct a trial that's capable of measuring an outcome that's relevant in this population that are close to the end of their lives in many cases? Because such a trial, which might look at mortality or pulmonary embolus events, as Dan's pointed out from the review in the lower limb immobilization group, those events happen very infrequently. Now, they're clearly extremely important to those individuals, but if you're going to run a study that can answer that question, then you need many, many thousands of patients. The second problem is that in reality, people that come through the hospital with hip fracture meet many different clinical services and very few independent. I just seen a question in the chat. No, slides are coming. I'm talking to you first. Very few independent decisions are made around prophylaxis in reality. For admitted surgical patients, we generally do what we're told by the thrombosis committees, make sure there's no, our local thrombosis committees, make sure there's no contraindications, and then proceed with the overarching recommendation. And that means that the idea of individually randomizing people that are going to move through 3 or 4 or 5 different services and hope that that randomization persists is extremely difficult to imagine. And so really we were interested in a hospital level intervention, which takes us away from individual randomization and towards cluster randomization. So I am now going to just share my slides. I've got 2 slides for you which summarize the study. Okay, so here is the study in a nutshell. It's a 4-year study, so it's much faster than TiLLI. So you'll all be glad to know that we'll get our results at least 6 months earlier. And not that Dan and I are competitive, not at all. And it's big, right? So we need 96 hospitals. And when you work out the sample size for this cluster trial, 96 hospitals that are treating patients over the course of 1 year, that comes to just shy of 22,000 people are going to be randomized at cluster level. And it's a little bit more complicated than just a normal cluster trial. So in a normal cluster trial, you would receive an allocation, and that would be your treatment, whether it be aspirin or low molecular heparin, for the duration of the study. In order to get more power and to be able to answer these questions that happen very infrequently, we're doing a cluster crossover. So what that means is that the 96 hospitals are randomly allocated to their starting treatment, whether that be heparin or aspirin. Then they cross over halfway during the study to the opposite, and that really ramps up the statistical power of the study. And so we are able to deliver the study in 10 months of recruitment, and with a 2 months washout in the gap to make sure we sort of fine-tune the hospitals and get them into the mindset of changing their practice. That comes to 12 months of recruiting patients. So it's a really fast study considering how big the target is. And then we've got this interesting 9 months funding freeze. So essentially we're not going to do anything for 9 months, and we're going to wait for the outcome data to become available. And one of the exciting things about this trial is that it is embedded in 2 different systems. The first is that we are using the National Hip Fracture Database and the Scottish Hip Fracture Audit, which are 2 registries that tell us everyone in the UK that's been treated for a hip fracture. And then we're going to link that to their outcome data, much like TiLLI will do. And we're going to use the routinely collected data in hospital episode statistics and indeed the other devolved nations' similar administrative data sets. And so the burden of follow-up is really low, and that's really important because this group of patients are really tough to follow up with remote phone calls or letters in the traditional way. So that's what we're proposing. And that took, I had a little look before the call when I first started writing in my documents on Direct. And 2016, I wrote the first concept down on a document. And it's now 2024, so 8 years. It's taken a while to convince the funders that this was feasible. And this really tells you what's happening in the back end of the trial. So it's a complicated diagram, but it's got lots of parts to it, but it's not actually that difficult to follow. So on the left-hand side, you've got the National Hip Fracture Database and the Scottish Hip Fracture Audit. So these are registers that basically have 100% compliance because this is how you get paid for treating people with hip fracture. And we collect these routinely, and they tell you who sustained the hip fracture, which hospital they sustained the hip fracture in, and when they sustained their hip fracture. And those are the key things that we need to know in order to be able to understand who was exposed to the treatment during the randomization episodes that I showed you in the previous slide. We can collect some interesting information about their baseline characteristics, their age, sex, but given that 96 hospitals need to participate and there's only 150 hospitals or so treating hip fracture, I'm pretty sure we're going to have a representative group. And then what we do is we take out all the identifiers, so NHS number, sex at birth, date of birth, and postcode. And we pump that information across to the big national data sets. And we've got Wales, Northern Ireland, Scotland, and England, each of which keep their own independent register of hospital activity. And there we have diagnosis and procedure and investigation codes, and we were able to extract a degree of information, not highly granular, but probably the most important things like diagnosis of PE, cause of death, information like that. And all of that information that gets pumped back into the university, and we link it up with the National Hip Fracture and Scottish Hip Fracture Audit information. And then essentially we have our bespoke data set ready for the analysis. So in summary, we are doing a superiority study. So we're looking for a benefit between aspirin and low molecular weight heparin, both extended duration, in hip fracture patients, 22,000 across 96 hospitals, in a cluster crossover design, which is both embedded in registries and data enabled. So it's pretty punchy and out there in terms of standard trial design. This is sort of right at the edge of what people are doing at the moment. And I think that's why it's taken us some time to get it funded. But I think it also opens up the possibility that we could do other similar, very large trials where we're asking simple questions for really common conditions. Thanks, Beverley.
Well, thanks, Xavier. I think one of the issues is consent here. Can you tell us, are you doing personalized consent or not?
Great question. So cluster trials are a special type of trial from the point of view of consent. So there's a statement which the HRA is signed up to called the Ottawa Statement. And that is around the sense or otherwise of asking somebody for individual consent if they are in a cluster where the treatment they would receive is going to go ahead irrespective of whether they consent to be in the trial. So just to unpick that a little bit, what's going to happen is my hospital, Bart's going to join the study. We're going to be randomized to, say, aspirin. At some point, we'll cross over. And then the thrombosis committee will say, okay, from now on, for the next 6 months, we're doing aspirin. We'll change the guidance. We'll change the electronic prescribing systems that we have. Everyone that has a hip fracture that comes in is getting aspirin, unless they've got a contraindication. In that circumstance, it doesn't really make sense to a patient to say, are you happy to participate in a trial? Because it's a false choice. They're going to be offered aspirin as their first line therapy. There is a second part to the consent, which is, are you willing to have your data processed, your personal data processed for the purposes of the trial? And that's a legitimate question to ask somebody because they could opt out. But the ethics committee agreed with us that the burden of follow-up here was so low and the impact on the patient was so low because we're not asking any, provide an opt-out system rather than an individual opt-in. So for hospitals on the ground, there won't be any routine individual consent requirements. All that will be required is a poster and appropriate information in the clinical environment that people with hip fracture could see and choose to opt out.
I think this is enormously important information because it means you don't really need a research nurse to go out and consent all the patients, which is where a lot of the cost and the time of the effort of all the other studies is. And this really is a new way forward. So it just requires the consent of your orthopedic surgeons and your thrombosis and thromboprophylaxis committee. And it's incredibly exciting that we have got a cluster randomized trial in thromboprophylaxis starting. So it's a big congratulations to you, because you have worked on this for many years. So to get it going is a triumph. Mind you, it's a triumph for all the other studies too, because they were pretty hard to set up. Is there anything else that you want to say? We need more centres, or have you
we
got
need 96 centres. So
yes,
I would love centres to contact us, and I can distribute our contact details. The key thing for us in terms of the pilot phase, NIHR like a pilot phase. They like to de-risk their funding. So quite early on, a year in or so, they want to know that you're on track. And typically that means you've set the trial up and you've started to recruit, and you're hitting your recruitment targets. The issue for us here is that we're not recruiting, as you point out, Beverley. So we don't have research nurses on the ground recruiting individuals. And so that doesn't make much sense, because chances are the patients are coming in at the same rate that they always have done with hip fracture. So what we need to do at the beginning of at the end of our pilot, which is 12 months in, is we need to have 96 hospitals lined up, ready to open. Yeah. And so I don't have time on my side to recruit centres into the study. So I'd love to have 96 centres knocking my door down right now saying, we want to be part of this study. So that's the big appeal. That's the action.
We need your email in the chat, please, for the trial. And then one of the questions in the chat is, what dose of aspirin are you recommending? And what do you do if someone's already on clopidogrel or some other antithrombotic? I presume there will be instructions, very strict instructions from the trial team in that setting.
There is very strict instructions. And if I summarize them here without having my wonderful app open, and those of you who have got the app, the recommendations that Beverley and the team have produced, you're
talking about the thrombosis app?
Yes, many of you will recognize the flow diagrams that we recommend to the thrombosis committee. So what we are trying to adopt is essentially a very pragmatic process where we are asking thrombosis committees to institute everything that they're familiar with doing, whether it be low molecular heparin, and all that we're asking them to do is to substitute out the low molecular heparin for aspirin. Everything else remains the same. And so all the bridging considerations, people that are coming in on pre-existing anticoagulation, people that have already got DOACs on board, all that's factored in. And everyone that's familiar with those relatively complex first-line treatment algorithms will spot, oh, this is identical. Yeah.
Okay, and for those who don't know on the call, Guy's and St Thomas's, we have our own thrombosis app. It's freely downloadable from the iPhone and the Android stores, and it has got every single version of how to use anticoagulants and do thromboprophylaxis and treat VTE in beautiful algorithms that we spent a lot of time on, and it fits in with nice guidance. So we would encourage you to use that. Don't have a look at it. You can have it on your phone in the middle of the night when you're thinking about thromboprophylaxis. Okay, I think we've dealt with most of the questions that are relevant to your study. I think there's some enthusiasm there to join the study. Oh, Stefan says, can we have a link to the app? It literally is looking in the app store, Stefan. Just type in thrombosis and it comes up, and it's a teardrop shape, white on red. Oh, Joe's done it. Thank you very much. Okay, I'm not sure that there are any more questions. Is there anything any of the panel would like to say? Well, I'm just overwhelmed with the wonder of the trials that we've got going in NHS England, and I thank you all. I thank the NIHR for the funding. I know there will be another trial funding call very soon. It will be around thromboprophylaxis in pregnancy, which is a evidence-free zone. There have never been big randomized controlled trials in pregnancies. That's going to be very exciting. A big thank you to all of the wonderful panelists for their lovely presentation.